Good evening, everybody. Welcome to the second webinar on the topic of epilepsy surgery, drug refractory epilepsy surgery. This is a CME program being conducted under the auspices of Indian Society of Stereotactic and Functional Neurosurgery. We are running a series of webinars on separate topics. We've had 2 webinars on stereotaxy. We've completed 1 webinar on epilepsy surgery part 1. This is the second one, and the third one is due next Thursday. Indian Society of Stereotactic and Functional Neurosurgery conducts these webinars with the aim of improving the awareness in functional neurosurgery and trying to increase the interest which is taken by the younger neurosurgeons and of neurosurgery and neurology together to try and improve the awareness in this functional aspect of neurosciences. With that sort of brief introduction, I would like to introduce Dr. VP Singh, a close friend of mine and the head at Medanta Institute, Delhi. He has been the ex-president of Indian Society of Stereotactic and Functional Neurosurgery and a very active member of the same, and is the president-elect of Neurological Society of India just now. Dr. VP Singh is going to moderate this session, and I'd like to request him to take over from here. VP Singh, do you want to take over, please?
Right. Thank you, Milind. Good evening, friends. We are now going to start the webinar, the second on the epilepsy surgery, and we have a very distinguished panel here. We are going to start with Dr. Anita Mahadevan. She is the professor of neuropathology at NIMHANS, Bangalore. Normally, we let the pathologists have the last word, but to be different in the epidemic and the pandemic, we're going to let her start the process and have the first word. So, Anita is going to be talking about neuropathology of drug-resistant epilepsy. Anita, you have 25 minutes to speak.
Thank you, Dr. Singh. I think I'll begin by thanking Professor Bhaskar Rao for the invitation. Without losing much time, I think I'll just start. And thank you for having pathology first. And we are generally used to being the last. So I know that all of you are aware that a lot of advances have come in this field. We have understanding in pathology, which has gone on to physiology, thanks to animal models. A lot of in vitro models that is giving us more insights into cellular and molecular mechanisms. The good news is that I'm not going to be covering all of this. So I'm going to be sticking only to the surgical neuropathology. That is what has been asked. So very briefly, we'll look at what we already know, how it started, what is the spectrum. I'll be giving some of the details that we have collated from our own data, the numerous classifications that are there and what we currently follow, and kind of end with what we do not know. So on a historical perspective, the clinical pathological relationship between seizures and hippocampal pathology dates back to more than 150 years. Now, Boucher, and I'm not really sure how to pronounce his name, way back in 1825, interestingly looked at 18 autopsy patients, and they were the first to describe that the hippocampus would be hard and shrunken. And it was Sommer in 1888 who gave the first microscopic description. He also predicted that there is a pathological relationship between hippocampal damage and the clinical seizure symptoms. But the credit of the accurate microscopic observations, which we use even today, goes to Bratz way back again in 1899. He also observed that the hippocampal sclerosis generated a certain type of seizure, and this may be associated with early childhood convulsions, which is something that we all know very well today. So the beginnings, you could say, of surgical treatment in epilepsy started then. And with so much of advances in treatment and investigation of epilepsy, there are several centers having epileptologists. So I must say that there is enough volume to keep us neuropathologists pretty busy in practice. So the focus of today's talk would be the surgical neuropathology of the specimens that come from epilepsy surgery. I will, of course, not be touching on any of the primary generalized epilepsy without a seizure focus, whether from genetic abnormalities or ion channel or metabolic defects. I'll start off with our own scorecard. We looked back at about 2 decades of our own data, which essentially compares very well with what Blumke put out in 2014. The classification systems of these two studies are similar. And as you expect, hippocampal sclerosis is the most common, followed by focal cortical dysplasias, other malformations of cortical development, neoplasms, vascular malformation, and rasculations. So we'll essentially be looking at only those today. So we will start off with the most frequent, which is the temporal lobe epilepsy resection specimens. Several pathological entities we know can be associated with temporal lobe epilepsy, from hippocampal sclerosis, malformations, tumor, trauma, inflammatory. So the evaluation, if you look at, of the surgical specimens essentially addresses, one, the anatomical components, which is the temporal lobe, the hippocampus, and the amygdala. Two, we look at whether there is presence or absence of hippocampal sclerosis. And third, whether there is any focal lesions. So we need to remember that the accuracy of a pathology report is essentially dependent entirely, I would say, on the type of surgical specimen you give us. If you give us something in bits and pieces like this, then we would be hunting for a hippocampus, and essentially we will really not be able to analyze this. So not all surgical procedures produce tissue amenable for neuropathology analysis. So if you wish to use a QSA, don't bother to send us any specimen for pathology. Of course, en bloc resections like this, where you have the entire hippocampus in the temporal, we've got it only in the hands of Dr. Bhaskar Rao. And this is essentially a pathologist's dream, to have the entire en bloc resection. So once we do get this hippocampus, you know that we use several terms. Important for you to understand what these several terms mean. So when we use the term Ammon's-Horn sclerosis, we mean that the changes are restricted to the Ammon's-Horn alone. That is the correct anatomical terminology that should be used. Hippocampal sclerosis is basically synonymous with this, but when you use the term mesial temporal sclerosis, we must remember that we are referring to changes not isolated to hippocampus, but in addition, there are changes either in the amygdala or in the medial temporal. So just keep these things in mind. So this is a normal hippocampus for you. We like to have the entire hippocampus in toto because we need to coronally slice this. So this is what it will look like on coronal slicing. You can see the beauty of the hippocampus here. This is an atrophic hippocampus from a surgical specimen. And you can see the marked atrophy that the entire hippocampus undergoes. So what is the pathology that we see when we look at this hippocampus? We'll just look at two things. One, whether or not there is neuronal loss. And two, consequent to this neuronal loss, whether we see gliosis or not. Now you need to remember that certain things are spared. The subiculum, the dentate gyrus, and the CA2 sector of the Ammon's-Horn is generally spared. There is a distribution of these changes from an antero-posterior axis. So that is why it's important for you to give us the entire length of the hippocampus, and we need to be able to examine a well-preserved coronal slice of the mid-body of the hippocampus to be able to diagnose this confidently. So what is it that we use as stains? We just need to stains. We no longer use this missile stain. We use our fancy immunohistochemistry, and the most important for us, the most critical, is this NUN stain, beautiful marker of neurons, gives you the dentate gyrus and the neurons of the Ammon's-Horn subfield, the CA4, the CA3, the CA2, and the CA1. So this is a normal one. In contrast, you can very clearly identify that there is a depletion of neurons in the CA4, CA3, as well as the CA1. As I told you before, CA2 is relatively resistant. So there are several classifications which have been used to grade hippocampal sclerosis. Historically, it's the Weiler grading, which was the first to be used. Remember that this is completely out of use now, simply because they use arbitrary cutoff, and Weiler kind of assumed that all the sectors that we were talking about has a uniform degree of neuronal loss, which is not really the case. So ILE in 2013 brought out this very simplified, easy to use classification system, which grades it as grade 0, 1, 2, and 3. Grade 0 essentially means that there is no neuronal loss, even though on imaging you see shrunken hippocampus. You call it a type 1 when the loss is in sector CA1, 3, 4 with or without CA2. You call it type 2 when it's in CA1 alone. You call it type 3 in CA4 alone. This is an illustration where you can see preserved neuronal loss in all subfields. That's a grade 0. You see neuronal loss in CA4, CA3, CA1, 2 being relatively preserved. This is the classical type 1. This is what we see more than 90% of the time. CA1, isolated CA1 is type 2. Isolated CA4 is type 3. Type 2 and type 3 is very often called atypical patterns because they're very, very rare in all series that have been published so far. Now, why should we classify hippocampal sclerosis? What relevance does it have? I think epileptologists will always say that the duration, the frequency of seizures has really no effect on the pattern, whether it's a grade 1, 2, or 3. But it does seem to have some prognostic significance as in post-surgical outcome. The grade 0 and the atypical, which is a grade 2 and grade 3, invariably has a poor outcome. Okay? And this is essentially what we saw in our own series also. 70% who had an Engel grade 1 invariably had a HS type 1. Okay? In 10 patients, we had a grade 0. And interestingly, we had a dual pathology in 24%. Meaning that in the temporal lobe, which accompanies the resection specimen, we did find evidence of dyslamination. So just keep that in mind. A question, what makes hippocampus vulnerable, is something that you neurologists always talk about. We know that the hippocampus is very, very prone because it has a very low threshold for seizure induction, simply because it has a circuit which starts and ends in the hippocampus. Okay, so we won't go through this anatomy because we don't have the time, but keep this in mind. And all of this entire pathway is powerfully glutaminergic, which is why you have excitotoxic damage. And we know that the neurons in the hippocampus is lost, it disappears. It is all because of excitotoxic damage. So why is it restricted to only these areas? Why is it vulnerable? Answers come from neurophysiology. All of the neurons which have a rich calcium buffering property will be resistant. So CA2 has high calcium buffering, dentate gyrus and subiculum have very high calcium buffering properties. Whereas CA4, CA3 and CA1 have very low to absent calcium buffering, and that is what makes them very susceptible to neuronal loss. So that explains the reason why we see this kind of a pattern on pathology. Now, what is it that actually causes seizures? All the time you always tell us that we don't know whether it's the cause or whether it's the effect of seizures and neuronal loss. So what is it that causes seizures is something that still remains an open question. It could be intrinsic neuronal properties. It could be a metabolic dysfunction. It could be energy failure. In fact, currently we are trying to look at whether it's mitochondrial damage that is probably making these more susceptible to neuronal damage. We still don't know. But beyond the neuronal loss, there are several pathology that we don't often speak about. One is the presence of reactive gliosis. The second is the dentate gyrus neuronal changes. And the third is the mossy fiber sprouting, which we always say is one of the pathogenesis for hippocampal sclerosis. So this is a GFAP stain. That's a normal, wherever the brown is the normal distribution of glial fibers. When you look at a sclerotic hippocampus, you can see the entire thing has become intensely brown. Reason? Gliosis. So that's the degree of gliosis that accompanies the neuronal loss. Now, what about the dentate gyrus changes? We used to say always that dentate gyrus is resistant, but now we recognize that there are several changes that can occur. For instance, you may have a dispersion of neurons to the extent that you can get a double layer. All of these was what gave the basis for the interest in neurogenesis in epilepsy. I think we should leave that aspect to Dr. Bhaskar Rao. He can talk hours together on that. So we'll move on. Mossy fiber sprouting is also known as the kindling phenomenon, is believed to be one of the pathogenetic reasons for epilepsy arising from the hippocampus. So remember that the dentate gyrus is a gatekeeper. Anything going wrong with the dentate is what predisposes to epileptic seizures coming from the hippocampus. Are the changes restricted to hippocampus alone? Answer is no. The amygdala, if you look at various studies, 35 to 76% have shown evidence of gliosis and neuronal loss, but that, interestingly, is restricted to the basolateral nucleus alone. So it depends on what we get. And remember, we always get fragmented bits, and amygdala, honestly, is very, very difficult to know which nuclear area it is. Okay? The entorhinal cortex, interestingly, people believe may be responsible for seizure generation and maintenance. And many people now are trying to look at the pathology of the entorhinal cortex. I have no personal experience and changes there, but you'll see a lot of new articles which is talking about entorhinal cortex. So the question that would be relevant to surgeons is, should we remove hippocampus alone, or should we still remove hippocampus, amygdala, and medial temporal for better seizure control? I think if you look at our own data, I told you that 24% did show an extra hippocampal dual pathology. So I think, to us at least, we feel that it is good to remove the adjacent amygdala and medial temporal too. Move on now to the second most common, which is the non-hippocampal sclerosis lesions, which in our own series, neoplasms have been the second most common, followed by focal cortical dysplasias and several other things, particularly Rasmussen cysticercosis, glial scars, and vascular malformation. The seizure freedom in this group has been seen in 2/3, which is comparable to world literature. So we'll start off with the focal cortical dysplasias, which is a part of the malformations of cortical development. Now, malformations of cortical development again has several classification schemes. Everything, if you can break it down to the steps of neuronal migration, that is what the entire classification is based on. So we know that the first step is neurogenesis, followed by migration, and then the cortical lamination. So accordingly, the Barkovich classification divides the cortical malformations into 4 groups based on which step is interfered with. Remember that each of these steps are tightly regulated by genes. And now we know that each of the microcephaly, hemimegalencephaly, all have known genetic mutations. Okay. So essentially remember that most of this hemimegalencephaly, polymicrogyria, etc., we don't usually get it as surgical resection specimen. So I'm not going to go into that. We will go to the most frequent, which is the focal cortical dysplasias. Several classification schemes we know have come into focal cortical dysplasia, starting in 1971 when it was first described, followed by Pamini in 2004, who gave the very first classification. We now follow Bloomke's 2011 classification, which is a consensus statement from several countries which participated in it. There is, however, a lot of advances. In 2000, there is a lot of genetic correlation information which has come in. And in 2012, genetic correlation of the FCD1 has also come in. So we are waiting for the update. They said it will come out in 2018. We are still waiting for a new genetic classification of FCD. Until then, we follow the 2011, which we know is divided into 3 types, the type 1, the type 2, and the type 3. The type 1 is essentially architectural dyslamination. The type 2 has cytological changes, which includes dysmorphic neurons and balloon cells. A type 3 was introduced in 2011, which includes type 1, which is dyslamination, plus a second pathology, which could be hippocampal sclerosis, tumors, vascular malformation, or any other lesion. So very quickly to go through, N is the stain that we use even for focal cortical dysplasias. That's the normal preserved cortical lamination where you have alternating granule pyramidal layers. Now this is an example of an FCD type 1. Dr. Bhaskara gave me these intraoperative pictures. Very difficult to say which is the gyrus, which is kind of expanded. When we look at the resection specimen, this was a 5-year-old child with a right occipital lobe dysplasia. You can see that this is a Luxol fast blue, white matter standing out blue, and the entire gray matter standing out pink. And if you look at all of these areas, beautifully preserved gray-white distinction. Thin cortex, when you look at just only this area, you can see a widening of the cortex. Okay, when you look at this up close, this is normal, this is the widened area, and here you can see that the alternating granule pyramid is replaced by columns of only small granule neurons. This is what is classical type 1A, which is the radial dyslamination, where we call these as microcolumnar arrangement. So FCD type 1 has A, B, and C. A is a radial dyslamination. 1B is what is called as a tangential dyslamination, where there is a missing layer. It is usually layer 3 or layer 5, where you have granule neurons. Now, there is a type 1C, which is a combination of both radial as well as tangential dyslamination. Extremely rare. We have never seen a case of 1C. Even Bloomke's series has seen only one case. Now, the type 2 is what is the most frequent, where you have your characteristic imaging abnormalities with the widened gray cortical, with the blurring of the gray-white distinction. Sometimes you also have a transmantle sign. What is it that corresponds to is a widened gyrus. You can see a blurring and thickening of the gray-white junction. In 2A, the characteristic cell type are dysmorphic neurons, which accumulate what we term as phosphorylated neurofilament. So here you can see the large bizarre neurons accumulating neurofilament. That is what defines a dysmorphic neuron. Type 2B is classically where you see your balloon cells, which I think all of you know it as Taylor type cells. Where you have this huge glassy eosinophilic cells. They accumulate both GFAP, which is a glial marker, as well as neurofilament. And therefore, people believe that these are probably stem cell in origin. So this is our own scorecard where we found that FCD2A and B constitute the most frequent type of FCD, followed by FCD1. And we also had the FCD3, A, B, C, and D. I'll just show you examples of that very quickly. So the FCD3A is where it's associated with tumors, and the glioneuronal tumors have been the most frequent, followed by the low-grade gliomas in our series. This is characteristical features of a dysembryoblastic neuroepithelial tumor, where you have the glioneuronal columns, and that is the synaptophysin and neurofilament state. This is the adjacent cortex, where in 4% of cases, we saw evidence of dyslamination. The hippocampus was normal. So remember, in 4.3%, the adjacent cortex can show dyslamination. When this occurs together, we call it an FCD3A. This is ganglioglioma, which is second most common glioneuronal tumor, the classic solid cystic ring-enhancing lesion, typified by these very large dysmorphic neurons in the glial component. What is the pathogenesis of this? Several schools of thought, whether the tumor itself secretes molecules which make the tissue epileptogenic. Is it mechanical compression? Is it infiltration? Is it the dyslamination adjacent to it? Is it genetic factors? We don't know. Vascular malformations, we've most often seen cavernomas, and again in 4% we have seen adjacent cortex showing dyslamination. Rasmussen's encephalitis, quite a large proportion of cases, and Dr. Sinha will probably be talking about those lesions. And this is neurocysticercosis with drug-resistant epilepsy, where you can also see a dense gliosis which surround these cysticercal cysts, in addition to dysmorphic neurons. The post-traumatic destructive ischemic lesions also show dense amount of gliosis. So if you actually look at it, in all of these lesions, the glial component is also a very prominent part of the lesion. ILAE, of course, defined another glossary of terms, which is dual pathology, which is HS with any other epileptogenic lesion. You call it a double pathology when you have two principal lesions, each of which is independently epileptogenic and usually occurs not in the ipsilateral lobe, but in different lobes, anatomically distinct. Okay? For example, you could have tumors and vascular malformations in different lobes. That is called as a double pathology. So that's about what is known. What is still not known, of course, is about FCD1 itself. It's a new entity. We still don't have a comprehensive clinical phenotype, reproducible imaging characteristic, and specific molecular or genetic biomarker. Okay? FCD3 is still very controversial because many people cannot understand how you can get an FCD, which is a non-developmental, right next to a non-developmental lesion. For example, you have a tumor. How is it that you can get a dyslamination there? We still don't know. There is no neurophysiological imaging genetic biomarker to reliably classify FCD type 3 also. Now, of course, you have the molecular era. A lot of genetic mutations have been identified, particularly in FCD2. The mTOR pathway has been implicated, and there's a lot of interest in the new therapeutic strategies which this throws up. Interestingly, FCD1 also has been associated with SLC35A2 mutations. Okay? So this is probably going to lead on to an integrated clinico-pathogenetic classification, much like the WHO classification. So the mystery still remains, is hippocampal sclerosis the pathology we see cause or effect? We still don't know whether it's neuronal or glial in origin. A lot of interest that it could be glial in origin. What is it that is responsible for drug resistance? A lot of questions which remain unanswered. Of course, a lot of interest now in imaging, and probably that's why the organizers thought that radiology should follow us. And I'm hoping at least that very soon imaging will replace us. So on that note, I will end this and probably set the stage for Dr. Keshav to take over. Thank you very much. Thanks to this entire team who's taught me all of the epilepsy pathology that I know of. And thank you for your attention.
Hello. Yes. Thank you, Anita, for a very nice and very elegant presentation. I think it was very enjoyable, and we will have questions after the next talk. So the next talk is by Dr. Kesav Das. He's a professor of radiology and Sri Chitra. So although his topic has been written as neuroimagining of drug-resistant epilepsy, I believe he'll be talking about the neuroimaging part. Dr. Kesav Das.
Okay, can you see my slides?
Yes, certainly. Coming well.
Okay. So what I will be discussing in the next about 25 minutes is about the various epilepsy substrates which can result in intractable epilepsy. And Dr. Anita has already explained the common epilepsy substrates and what epileptologist or a neurosurgeon or a radiologist should be looking at in the MR images. And MR, as you know, is the technique of choice in patients with intractable epilepsy. So the most common condition is the hippocampal sclerosis, where in the T2 weighted sequence, what you're looking for is a hyperintensity of the hippocampus, which is small in size. So hyperintense hippocampus, small in size. Now, is it T2 weighted imaging enough? No, sometimes you might have to look at the flare sequence, which will show this hyperintensity much better, and also the inversion recovery sequence. But this is not always needed. But you can look at these images to be sure about whether these signal changes are there. The second thing that you are looking for is the volume loss. Compare with the opposite side, or there are volumetric estimations can be done by quantitative methods, but you should look whether the volume is decreased. Now, where you should look for this? You should look at the volume loss and the signal intensity at the head, the body, and the tail. And before that, you have to see that whether the IAC, the internal auditory canal, are at the same level. Otherwise, you will be comparing the head of one side with the body of the other side. So, and you will make a lot of mistakes in the volume. So, look at the whether the IAC, the internal auditory canals, are on the same plane, and then look at the signal change and the volume of the hippocampus. Other than the hippocampus volume, you should also look at the volume of the fornix, which can be atrophic. You have to look at the mammillary body. It could be atrophic on one side. Loss of hippocampal digitations. So usually you will see digitations. You can see here digitations which are not there on this side, which has become flattened. The hippocampus has become flattened here. So look at the digitations and a dilatation of the temporal horn and the choroid fissure. So these are the other changes that you have to look for. Another important thing that you have to look at is the gray-white distinction of the anterior temporal pole, which is called the temporopolar changes. So there you can see that between the right and the left side, there is the temporopolar changes with a poor gray-white distinction is seen on the right side. And there is some amount of volume losses which is also coming. So this has to be reported. Sometimes this could be, as Dr. Anita was telling, dual pathology, a temporal lobe dysplasia along with the hippocampal sclerosis. So there is a hippocampal sclerosis, and this could represent the poor gray-white distinction, could represent an FCD also. But what we usually do is we usually report this as a poor gray-white distinction and a temporopolar changes along with the hippocampal sclerosis. Now, sometimes you land up in situations where you are not very sure whether there is a hyperintensity. One radiologist might say there is some change, others might say it is not. So doubtful cases are there. Similarly, you might land up in a case where there is bilateral change and you do not know which side is more involved. In such cases, you can look at the quantitative techniques like volumetry. You can actually do the measurement of the hippocampal volume, or you can do the T2 relaxometry, where it gives the T2 relaxation times. So these are the techniques, quantitative techniques you can do. Now, with the availability of 3T MR, the internal architecture of the hippocampus can be much better seen. The cornoammones, the dentate gyrus, the entorhinal cortex, all these things are much better visualized. Now, this is a patient where both the hippocampus looks perfectly normal in comparison to here, where the left you can see is abnormal. The internal architecture, the cornoammones, the dentate gyrus, all these things are not very well seen here. So the left is abnormal. So such good description of the hippocampus, of the internal architecture, can be obtained with the 3T MRI. And even people have come out with a hippocampal internal architecture scoring system, where you can actually score 4, where you can see this the cornoammones and the dentate gyrus very well. The gray-white distinction is very well maintained, while in one you can see nothing is seen, the very poor internal architecture. So this is the third thing that you have to look for, other than the volume loss, the hyperintensity in the T2 and the flare sequence. The third thing that you have to look for is whether the internal architecture is maintained or not. So this is very, very important, especially with the 3T MRs. Now, you can also look at other techniques like the PET studies, for example, is one good method to lateralize, and you can see whether hypometabolism is there. Like in this case, you can see that right side there is definitely hypometabolism. Now, but what we have been using is, before PET itself, there is this technique of arterial spin labeling, which is a perfusion weighted sequence where no contrast is to be injected, which gives a very good information about hypoperfusion. And there is a very good correlation that we have seen between the ASL and the PET study. So this is a simple technique. We call it a poor man's PET, where it gives quite a good information. But remember, this gives information about perfusion, while PET gives information about the metabolism. Now, you can do the SPECT also for lateralization. This is the SysCom, where you take an ictal SPECT and an interictal SPECT, do a subtraction, co-register onto the MR, and find out the area from where the seizures is, whether it is the right side or the left side. So SPECT also can be used. Now you go to the second pathology about which Dr. Anita was discussing, and that is focal cortical dysplasia. Thickened cortex is there in this patient who had intractable seizures since 7 years, very high frequency of seizures. And what you see is the classical transmantle sign and the balloon cells in the pathology. So when you get the transmantle sign in the T2 or the flare sequence, then you are almost sure. Otherwise, if you just see these images, you might even confuse it with a tumor. But also look at the abnormal sulcus. There could be an abnormal deep or widened sulcus. A poor gray-white distinction might be there. And if you see this transmantle, you are looking at focal cortical dysplasia 2B. But there is other type of cortical dysplasia, the non-balloon cell dysplasia, where there may not be any signal change in the T2 weighted sequence. What you might see is just a thickened cortex, a deep sulcus, and a poor gray-white distinction. These are more difficult cases to diagnose and easily missed. We have also missed several cases of these types of focal cortical dysplasias. So what we should do in such cases? So we have seen that when we have gone to higher strength of the magnet, the chances of picking up these lesions are much better. This 1.5 Tesla MR, quite a good MR. It was reported as normal. Now, when we did the 3 Tesla MR, the depth of the sulcus dysplasia, small hyperintensity here with a hyperintense band extending towards the ventricle, is much better visualized. So this visualization is possible, just like what I showed you in hippocampal sclerosis. 3 Tesla picks up cortical dysplasias much better. And now they say that 7 Tesla, though at present it is not available in India, picks up even much better. There are some studies coming. Now, depth of sulcus dysplasia, especially with 3D sequences. Now, this is another thing. Other than the 3T MRI machine, you have to look at the 3D sequences. And what 3D sequence is good? It is a 3D flare sequence, where you can actually see a small dysplasia in different planes, axial, sagittal, and coronal. And probably in one plane, it might not be very well visualized, But you can see that if you look at the coronal, sometimes it might be much better visualized. So a 3D sequence is much better. There is no interspace gap. You have about 140 slides, which is about 1 millimeter. Your voxel size is very small, and your chances of picking up these lesions in this high spatial resolution images is much better. So that is 3D, and it also gives a very good information about the extent of these lesions. Not only the picking up of these lesions, extent of these lesions, because you are looking at all the 3D planes. So do a 3D sequence, possibly the flare sequence. And whenever you report these, you should always do it on high-grade, high-resolution monitors, because if you adjust the windows, the chances of picking up these lesions are much better. You have heard that in stroke, if you just adjust the windows, the picking up of the stroke lesions are much better in the CT scan. Almost a similar thing is there, you can see in MR. You sit in front of these monitors and try to look at these lesions, adjusting it, and you might pick up these cortical dysplasias, especially the depth of the dysplasias are much better picked up. Now, this was a case where we had missed these lesions, but the information that the neurologist gave us allowed us to pick up the lesion. In fact, the neurologist came, it was a resident neurologist who was asking us whether there is anything in the right frontal region. And he had a suspicion that there is something here, probably which he was not seeing on the opposite side. A deep sulcus was there, a thickened cortex. There is no signal change in the flare sequence, as you can see. But you can see here in the axial. Also, a band can be appreciated if you carefully look at this. Now, these lesions can be easily missed, cortical dysplasias, but this was picked up because the information of electrophysiology is very important. So, the radiologist should be provided information about from where the seizures are originating, and also the clinical lateralization, localized. All these things are important when you look at these images. These are some of the difficult cases. What you don't see even a thickening of cortex. Only thing that you see is just a poor gray-white distinction, as you can see here. A poor gray-white distinction is the only thing. You compare with the opposite side, this is the only thing. And these are dysplasias which are more difficult. And you have sequences now, newer sequences are coming up. Double inversion recovery sequence is one of these sequences which is supposed to be good. This is a sequence which is gray matter only sequences where you can see these lesions. So people are coming out with various sequences to pick up these lesions because they are quite difficult to pick up. Also, whenever you have an information about PET and you have not seen anything on the first MR, then with the PET results, you go back to the findings in the MR. Like in this case, it's an old case of ours where the PET showed a lot of hypometabolism in the frontotemporal region around the insular cortex. And when we went back, you can see that the gray-white distinction of the basifrontal region here around the insula is quite poor. And in fact, it is enlarged also. This was a quadratic megalencephaly, which was in the initial scan missed. We had not actually looked. This was an old case, of course. With experience, we would not have missed it now. But you see the PET, with the PET results, we went back to the MR and it helped us in picking up these lesions. Now, just as I was telling you about the importance of ASL, here I would like to tell you the importance of arterial spin labeling in this particular case. Very frequent seizures in this young boy. You can see the flare sequence, T2 weighted sequence could have been reported normal. But if you carefully look, of course, there is some sulcus which appears to be slightly abnormal. Orientation also appears to be some thickening of the cortex. But even if you had missed it, you see the flare, the arterial spin labeling, so much of hyperperfusion from the lesion. So this was cortical dysplasia, which was producing a lot of seizures, and it was having hyperperfusion. Another case, a recent case, the history was a 17-year-old patient with intractable seizures, and they were saying that almost all the seizures were from the frontal region. And the MR, the routine MR was reported as normal. But in the arterial spin labeling, we were seeing something in the frontal region. And then we went back and started looking at the flare, and the flare picks it up. Thickened cortex, transmantle, picked up. So the ASL gave this information that you go back. So PET and ASL can give you the information to go back to your morphological imaging, especially your FLAIR images or the double inversion recovery sequence, the T2 images. Carefully look at for the transmantle sign and the thickened cortex, and you can pick up these lesions. So these are the imaging findings of the type 1 dysplasia and the type 2 dysplasia. You can see the type 2 dysplasia, you have the transmantle side, the cortical thickness, poor gray-white distinction. All these findings are much better seen, and pickup of these lesions are much better than type 1, where you just see some volume loss, some blurring of gray-white distinction, an abnormal sulcal or gyral pattern. These can be missed. So this is an important thing that we have to realize. Now, what are the other malformations of cortical development? You have the polymicrogyria with a bumpy inner margin of the cortex. You have the heterotopia, which could be a band heterotopia, the Scheissencephaly, the perisylvian syndrome with again polymicrogyria on both sides of the sylvian fissure. Then you have again the transmantle heterotopias, the hemimegalencephaly. So all these entities which can be picked up, but sometimes heterotopias can be very tricky. You might miss these lesions. This is another pathology. A 4-year-old child with epilepsy partialis continua, and there was right frontotemporal spikes. And what you see is there are, this is the first MRI, which shows that the ventricle on the right side and the sulci on the right side are slightly more prominent. And this is mainly in the frontotemporal-insular region. And there is some hyperintensity which is involving the caudate. So when you think of these findings, and when you do a repeat MRI, probably after about 6 months, you can see the atrophy progressing, with the caudate becoming more atrophy. Then you should think of Rasmussen's encephalitis. So Rasmussen's can all, the caudate as well as the putamen can show atrophy. So caudate goes through this putamenal atrophy, and the caudate atrophy can, which happens in Rasmussen's, can also go through several stages. Initially, you may just see a hyperintensity, then it goes for mild atrophic changes, then almost like an encephalomalacia, massive atrophy is seen with gliosis. So these are the stages of Rasmussen's encephalitis. Now, this was a very interesting case. Patient came with status. Patient who had an epilepsy was coming with status, and you saw gyral edema with an increased perfusion. And initially, we thought that this is just a post-ictal edema. There could be an underlying focal cortical dysplasia. Now, this patient again came after some time. At that time, the MR was looking normal. But 6 months again, after that, patient again had a bout of epilepsy partialis continua. You could see even restricted diffusion now. And at this point of time, it was becoming intractable, and the surgeon had to go and operate it. And this was the result from NIMHANS. It was actually Dr. Anita who had looked into this. They told there is intramyelinic edema. So, of course, there is edema. But what is the underlying thing? Could be cortical dysplasia, MELAS. But what we saw is after some time, the patient came and there was a hyperintensity and another area. And at this point of time, the NMDA was positive. So autoimmune encephalitis is another condition which you have to think of. And we are seeing more of these cases where you have this cortical swelling initially, and then after some time you can see the same thing at some other area. This has to be realized. And sometimes when it is a limbic encephalitis, where it presents with bilateral swelling of the hippocampus, later on going for an atrophy and hippocampal sclerosis, this is a very well-known entity which can cause for hippocampal sclerosis and intractable epilepsy later on. So autoimmune encephalitis is something which we have to think. This was a recent case. If you see these MRs, which was done in February, you can see a cortical thickening. You would have definitely diagnosed this as a dysplasia. Now, along with that, in the ASL, we saw hyperperfusion. Now, when this hyperperfusion was also seen, and which we have seen in cases of autoimmune encephalitis, I have seen it, shown you a previous case, we gave that possibility also. along with cortical dysplasia, we gave the possibility this could be an autoimmune encephalitis. Now, what happened is in March we repeated an MR in this patient, and actually the whole of this hyperintensity had disappeared, which does not happen actually in focal cortical dysplasia. So this was a case of autoimmune encephalitis. So this is something which we are noting now, especially people have already reported Rasmussen's encephalitis, very focal, around one sulcus you can have this sort of swelling, and this has to be always thought of. The next is a 16-year-old female, recurrent episodes of CPS with laughter. Of course, if the patient is having gelastic seizures, you will definitely look at the hypothalamus. But even otherwise, it is important for a radiologist when he is reporting a case of intractable epilepsy to look at the hypothalamus tuber cinereum, that region, especially in the flare sequence, because these lesions, the sessile hematomas, can be very, very, very small, and picking up these lesions sometimes can be challenging. So carefully look at these hypothalamic hematomas. Now, this was a case, quite an old case. We had missed this in the initial MR. This was reported as a normal MRI initially, but after a few months, this patient comes back again with seizures, and you can see that in the T1 weighted image, you can see a polymicrogyric cortex, which is quite large. So this is a polymicrogyric cortex, a large area in the frontal lobe, which is quite large also, so quadratic megalencephaly. Now, why we had missed it? Because here the myelination was not complete, and in the T2 weighted sequence, we could not actually pick up very well the poor grave eye distinction. You compare it with the opposite side, yes, it is there, the poor grave eye distinction. So in infants, we might have to repeat an MR. Sometimes it might not be picked up in the first MR. In the second MR, when the myelination is complete, this poor grave eye distinction, all these findings might be much better seen. So this is an important thing that we learn. And sometimes repeat MRs might pick up these lesions. Now we go to some tumors. This is the DNAT, classical appearance, hyperintense rim could be seen in some cases with small bubbly appearance. Sometimes you might have to distinguish it from gliomas. We have seen that spectroscopy helps in some cases because there is no active myelin breakdown. The choline might not be raised in comparison to gliomas where you can see an increase in choline. Then you have these glial neoplasms like ganglioglioma, angiocentric glioma, which is maybe having a T1 hyperintensity, a cystic area with enhancement might be also there. You might have to distinguish it with glioma. Then the presence of calcifications. Now, this is an entity which is quite common. And many of these patients with epilepsy, even intractable epilepsy, even now take only a CT scan. An MR is not done. And if that is not done, there is a possibility that you might miss these calcifications because in your T1, T2, these lesions might not be well picked up, and you will have to do a gradient sequence, a susceptibility. Nowadays, almost all centers have started doing this technique. Also, it is good. The susceptibility weighted sequence is good for picking up small venous angiomas, which sometimes can be associated with cortical dysplasias. Remember about dual pathology. This is an entity which was already described, and these sort of small heterotopias along with mesial temporal sclerosis sometimes can be missed. The heterotopia can be missed, and only dysplasia, mesial temporal sclerosis might be reported. Similarly, here is a case of a eulogyric cortex in a patient with an old hypoxic insult, which is another common cause. Now, what are these easily missed deletions, and why do you need to do a 3D sequence? The reason is, in 3D sequence, you can pick up these depth of sulcus dysplasias, small subependymal heterotopias like this, hypothalamic hematoma, which I showed you, and similarly gliotic lesions, which are related to an old granuloma, which results just in a small gliosis. If you don't do a 3D sequence and you have just 2D sequences, such small gliotic lesions will be missed. And this entity, the entity of temporal encephalocele, which this again can be easily missed. This was quite a large one, but small encephaloceles like this can be easily missed. So you have to do 3D sequences, carefully look at these lesions, which are important. Postictal changes are also important. Hippocampal swelling is one of the most common. Then you can have migratory lesions. You can have splenial abnormalities in periaxial changes. So this is the MRI protocol that we do, about 40 to 45 minutes. 3D sequences and 3D flare is what I have to stress. Also the arterial spin labeling. And lastly, a few slides on pre-surgical eloquent cortex mapping. Really,
I think we're running out of time. Okay, so continue.
Yeah, I will try to just 3-4 slides. One is the fMRI to look at the eloquent cortex to decide whether surgery should be done or not. A language area and the motor cortex is mapped. You have now resting state fMRI for visualization of that. The DTI to look at the Meyer's loop or corticospinal tract and the closeness of the lesion. And finally, the role of intraoperative ultrasound, like in this particular case, where the intraoperative ultrasound actually picked up this lesion very well. Actually, Anita was showing the difficulty in picking up these cortical dysplasias. So the ultrasound actually helped it to completely remove the lesion. So the take-home message is 3D MRI and 3D flare has to be done. Look for these subtle lesions, always include ASL. And before calling something like MR negative, carefully look at all the images once again. Thank you very much.
Right. Thank you, Kesav. That is a very elegant presentation, very well illustrated. Thank you for showing us such nice pictures and illustrating your talk very well. So we now come on to the discussion. I don't think we have any questions in the chat box.
Can I just interrupt? There are a couple of questions from the viewers, Dr. VP Singh.
Right. Okay, maybe you have them. Okay, why don't you start? Let's start with Dr. Anita.
Yeah, so there are two questions. One is a request to share the article scoring the hippocampal architecture. So that is one question. So that is one question. Dr. Anita?
Yeah, would be a pleasure to share. So maybe I can pass it on to Dr. Bhaskar Rao and he can share it.
Yeah, sure. We'll do that. Yeah.
Yeah.
It's actually available on the ILE website.
The other question is a little more clinical, but I'll nevertheless put it up here. What are the symptoms which goes in favor of a successful epilepsy surgery? This is from Dr. Vasudeva. So I think essentially what I would suggest is that Dr. Vasudeva probably needs to visit the ISSFN website. These talks are uploaded. They may not have been uploaded as we speak, but these talks do get uploaded on the Indian Society of Stereotactic and Functional Neurosurgery website. So successful epilepsy surgery candidates are discussed there, including the surgically remediable epilepsy syndromes. So there are no other questions from the viewers. Now I'll request Dr. VP Singh to moderate and find out if there are any questions from the faculty or from the moderators from the other speakers.
Yeah, let me start off with a question for Anita. Now, when we talk about dual pathologies, how aggressively do you look for the dual pathology, and are you following any protocol? I believe the more you look, the more you would find. So how do you manage that?
So that's probably very nicely put. The harder we look, the definitely we will find it. In fact, I must say that I had one of my residents doing a review of that 2-decade-long experience. And I think when we reviewed it, we picked up several. So yes, we need to look harder. But generally what happens is it's a very close correlation with the clinical and imaging. So that is something that I think we've always followed. So if there is something that they picked up on imaging, which we didn't, I always expect a call back from our clinician saying, this is something you missed. So we go back and look. There is no shortcut to looking hard. The protocol, if you ask, I think it is essentially the same that world over we follow. The ILE has very nicely put out the protocol for how to gross the specimens, what are the basic stains we need to use, and what are the features that define all of this. So I think if we stick to that, we are fairly good. So yes, I must admit that we did miss in the first round.
Right.
The good thing about ILA classification, I think personally, it has refined several entities which earlier had a very nebulous definition. So there was a lot of inter-observer, intra also. If I see it today, tomorrow I would say it is not there, you know. So I think that way ILA has really refined a lot of things, and that has helped.
So let's just take that forward a bit more. When you talk about the number of dual pathologies, what percentage of them would be visible on the MRI in retrospect? I mean, do we have a correlation between that in your center? Maybe Bhaskar could also add on to that.
Dr. Anita, you would like to answer that?
Yeah, so the dual pathology, I think I'll just define it. Maybe you can add to it. It's a HS plus. So where we have a hippocampal sclerosis with a second pathology. So that's where the radiology really is critical. There are other clinical aspects. I think over to Dr. Sinha and Dr. Bhaskar.
Yeah, I mean, these are, yeah, Keshav, please go ahead.
No, I just wanted to, from the radiology viewpoint, what we do is, whenever we see any pathology, say it is a gliosis or a vascular malformation, in a patient with intractable epilepsy, we always look at the hippocampus also. Because whether hippocampal sclerosis is also there. It might be in the same lobe or the opposite lobe or the temporal lobe or not other lobes, but we always look at the hippocampus. This has become a routine for in radiology reporting of epilepsy. Hippocampus has to be looked even if you find a lesion anywhere in the brain. A small gliosis or calcification, go and look at the hippocampus also.
So can I ask a question?
Yeah.
This question is to Dr. Keshav. Is that okay, Dr. VP Singh?
Yeah. I think if we can have a comment from Manda, how many of dual pathologies are radiological and how many are pure pathological? And that was basically the question.
There are a few points. I mean, mostly anecdotal and not probably data-based. See, for example, if I see a child with MTS, I always look for a dual pathology because hippocampal sclerosis takes time. So usually they may have some sort of neocortical developmental malformation. People who present with multiple semiologies, 2 or more semiologies, also we look for dual pathology. Of course, when there is a discordance between lesion and focus, lesion is right temporal, maybe focus looks like left temporal. Also, we look for dual pathology. Of course, now imaging is heavily guided by clinical semiology as well as by EEG. So, EEG guided review of the imaging also will give us some idea about dual pathology. When pathologist reports dual pathology, and then when we look back, always we find some clues of this second pathology which we missed initially. So I think our understanding, our pre-op identification is increasing. That's from my end. I don't know whether Dr. Sinha will add anything. And Milind has got a question, and I also have got a question to Keshav. Can I just finish
Go ahead. Go ahead.
So Dr. Anita concluded her presentation saying that imaging will replace pathology at some point. The way imaging is helping in glioma diagnosis, like you can identify gene mutation, same way you think there are advances in imaging which will help us to have better substrate identification?
Yeah. So the role of the usually the radiologist, once he sees a lesion in the brain, is to go as close to the pathology as possible. So nowadays, where the radiologists are trying to go into the genomics also, whether a genomic marker, radiological marker of the genomics is available, is what we are looking at. So if you say it's a glioma, whether we are trying to say whether it is what sort of a glioma, it is based on the genetics also. It is not just the high grade or the low grade. So there are markers also. And that is this whole setup which has come as radiogenomics is being facilitated by the development of artificial intelligence also. So a lot of new techniques are coming up by which we could tell what sort of a tumor it is. But we are far away from pathology. We know that. We are very far away. But we are trying to reach. There are a huge amount of mistakes nowadays being made when we go to the molecular subtyping of a tumor and all. But it is becoming better. Newer markers are coming, and that will definitely make it better. That's what I think. But I don't think we will anyway replace or reach anywhere, because they are going to change the classification after some time. So we have to, every 4 or 5 months, they will change our classifications.
I believe new FCD classification is coming in 2021. Maybe that will lead to you. I think probably Milind has got a point, and then
Milind.
So this is actually a little more towards radiology, trying to denote epileptic focus rather than trying to go into the radiological pathology. The question was more towards arterial spin labeling. Now, when you're talking in terms of ASL, can you actually emphasize on the role of ASL, particularly in HS? Because a lot of individuals who would probably want to start epilepsy surgery at their centers do not necessarily have the benefit of a PET. And I completely agree with you that ASL is a very, very good technology and a poor man's PET. And if you could just emphasize a bit more on the use of ASL in HS in particular.
Yeah. So when we started doing ASL, and in all these cases, wherever PET has also been done, we started comparing the findings of ASL in temporal lobe epilepsy, especially the hippocampal sclerosis cases. And then we found that in about 70%, about 70 cases, we were able to find the same thing what we saw in the PET as well as in the ASL. The hypoperfusion was obtained. So we cannot get the same thing in all the patients, but still in 70% it is helping. So I think we should put it in the protocol of epilepsy imaging whenever you are seeing a hippocampal sclerosis, and this particular sequence also, about 4 minutes of this sequence, it might help us to lateralize. So I think it has a role. Even in MTS, of course, in cortical dysplasia also, I showed you some cases where it is helping. In some cases, it shows areas of hypoperfusion. If the seizures are coming from one hippocampus, very frequent seizures, sometimes we have seen even hyperperfusion in that area. So all these sort of findings are there in ASL. Usually they are hypoperfusion is seen, but in few cases where very frequent seizures are there and there is a hippocampal swelling associated with that, we have seen hyperperfusion also.
Can I ask the last question? Dr. Kesav, artificial intelligence is coming in a big way in radiology to pick up tiny lesions which are difficult to find. Yes. Do you think any studies on cortical dysplasias using artificial intelligence?
Yeah, so this is an area of my interest also. Thank you for asking that question. Actually, we are working with NIT Suratkar in Karnataka, where there is a very good team who has been working on this focal cortical dysplasias for the last several years. And they have come with something called the UNET, which has been published in IEEE journal also recently. And they are continuing this work, which has got some DST, Department of Science and Technology funding also. So there is a lot of interest, and there are groups which are working. In Canada also, there is a group which is working on artificial intelligence. Yes, it is tough. Again, it is not an easy thing to pick up, but there are some way they are able to now pick up larger lesions and segment it. And they feel that it will be possible to even pick up these transmantle dysplasias at all. So let us see. We will have to wait for some 2-3 years more.
Right. Well, thank you, Anita and Kesav. It's been a good discussion. We now move on to the second part. This next speaker is Dr. Sanjeev Sinha. He's the professor of neurology at NIMHANS. He's going to be talking about role of EEG and MEG in the evaluation of drug-resistant epilepsy. Over to you, Sanjeev.
Must thank the society and Professor Malla to invite. Am I audible? So, am I audible?
Yes,
you are.
Please go.
You are.
So, my job today is to discuss in coming 25 minutes about the pre-surgical evaluation of drug-resistant epilepsy and the role of EEG and MEG, that is the electrophysiology part of it. So, last two speakers have dealt with the substrate part. Now, when we see patients with drug-resistant epilepsy, when everything fails, one of the options is epilepsy surgery. And this is one of the landmark trial from Canada. And all of the epilepsy surgery is picked up following this trial that two groups were followed up of refractory temporal lobe epilepsy who underwent temporal lobectomy and the usual medical treatment. So you can see the difference between the success of 58% versus 8%. Now, a patient, 30-year-old female nurse, she presented to us with episodes characterized by staring look, repeated jerks of upper limb and lower limb, making noise with each jerk, keeping her eye closed with some clonic movement. For last 5 years or so, multiple drugs, currently on 4 drugs with 2 to 3. Her MRI is normal and the EEG also was normal. This is her video EEG. So she starts having this movement. So the EEG is full of artifact, and this is actually a pseudo seizure or non-epileptic seizures. So one should first exclude that group, that is the pseudo seizures part of it. Now, once we are sure that the patient has drug-resistant epilepsy, these patients group we evaluate for epilepsy surgery, and the phase 1 is the non-invasive part. The phase 2 is the invasive part. And usual in the phase 1, all the patients, other than the review of the clinical history, which is very important, requires the EEG recording, the MRI, which has just been dealt with, the video EEG, neuropsychology, and if some patients require psychiatric evaluation. In the posterior cortex or posterior head region, epilepsy field chart, it becomes very important. Some patients may require PET or ictal PET. These are not required. MEG and fMRI in most patients, may be done in some. Now, there are some terminologies one should be aware when we talk about pre-surgical evaluation. We'll see one by one these terms, that is irritative zone or ictal onset zone. Now, this epileptogenic lesion was dealt in detail by Dr. Keshav, and this is what we see in the MRI is the epileptogenic lesion. Next comes the eloquent cortex. Now, how eloquent cortex? One is by knowing that, yes, suppose there is a clonic movement, that means you know that it is coming from motor cortex, which can also be substantiated by using fMRI. We can do neuropsychological assessment to see if memory is involved, or we can do even MEG evoked field or responses. The irritative zone is the routine EEG part, like when patients undergoes the scalp EEG, it is the irritative zone which we find out. The MEG also helps to find out the irritative zone. The EEG fMRI or the PET CT, the interictal SPECT, which is very less useful, can all find out about the the ictal onset zone is the most important, and this is defined by the video EEG. Like here you can see from the there is a build-up of the rhythmic activity, and that is actually found out by the ictal onset zone. The ictal SPECT also can find out, tell us about the ictal onset zone. Then come the symptomatic zone. The clinical history and the video semiology during the video EEG tells us about the symptomatic zone. Then the functional deficit zones, like what functions or symptoms patients had. Again, we get an idea from the history, fMR, and the neuropsychology. The most important is when we talk about the epileptosurgery, is a hypothetical epileptogenic zone. This is a theoretical area of cortex, that is, which when the surgeon removes, it renders the person seizure free. So this epileptogenic zone, we basically calculate based on this previous discussion of all the various zones. So today's first topic is of that Scalp Eg, and Scalp Eg is routinely used for all patients with epilepsy, and we know that it's a graphical representation of differences in voltage between two scalp locations. So we place electrodes over the scalp on various, and this is the potential difference between the two electrodes. And this is the brain, and the scalp is a poor conductor actually. So the generation which is happening in the neocortex has to be recorded on the scalp. So one should know about that. So signal source is here, and we record over the scalp. That is the EEG. Now, when it comes to epilepsy, the interictal discharges, that is IED, or the spikes, is a distinctive wave or complex which stands out from the background activity and resembling those recorded in a proportion of human subjects suffering from epilepsy. And spikes are very fast waves and are called spikes because of their shape in the EEG. Like you can see, these are spikes in the terms of history, like pointed piece of metal. So similar, it appears in the EEG. And the physiological hallmark is the depolarization which happened, paroxysmal depolarization. So I'm not going to bore you with the physiology. Now, one of the things which will be helpful when we come to understand about the MEG is to understand about the concept of dipole. So whenever any current flows, there is an electric field. Like you can put a battery there, and that has got a positive charge, negative charge, and a positive charge. And you know, from positive to negative, the current flows. So this is a current dipole. And magnetic field is perpendicular to that. So when there is a electric field, the thumb rule which we have read in our high school, so this is the current which is flowing, around that is the magnetic field. So in MEG we record this magnetic field, and in EEG this current is recorded. Now the MEG measures the minute magnetic fields by means of squid, which has circuit loops that conduct current indefinitely due to zero resistance. So if person is sitting in the gantry, this is the squid, and squid is bathed in the liquid helium because this squid transmits only at -270, and which can be provided only by liquid helium. So this is the prerequisite of any MEG machine. Now, MEG has got a very high spatial and temporal resolution. Now, MRI, which was dealt by Dr. Keshav, has got an excellent spatial resolution. EEG has got a very high temporal resolution. MEG provides both high spatial and temporal resolution because all patients undergo MRI, and what we see in the MEG recording, we try to co-localize or co-register on the human brain. That is the MRI. Another problem with the MEG field is that the MEG field in terms of the magnetic field is very minute or very small. So we have to pick up this in the machine. Now, how we do it, like the patient undergoes the MEG recording, within this what is known as magnetic shielded room, that is the outside magnetic disturbance is totally cut off from the inside this cartoon showing the MEG lab. Now when we measure that tiny signal from the brain, which very important that we cut off the outside magnetic field or the noise what is told in electrophysiology. Now MEG and EEG has got several differences, and we should not go into the debate of which is better. Rather, my point is that both are complementary to each other, and the most important point are that MEG is good for tangential dipole, EEG is good for radial dipole. So let us see some patients with temporal lobe epilepsy, and these temporal lobe epilepsies have past history of febrile seizures. They have an epigastric aura. They have a behavioral arrest, that is, suddenly they will arrest hypomotor state. They may have some automatisms or oromandibular like or limb automatisms, and they may not be able to recall what happens. Now this is a EEG showing spikes coming from the right temporal region. Now seizures in the temporal lobe may come from the medial temporal, that is from the hippocampal region, or from the lateral temporal. So naturally the medial temporal lobe, what I told was this was the symptoms. In the lateral temporal lobe, patients have more often giddiness or some kind of dizziness, rarely some hissing sound that can be in the lateral temporal lobe. Similarly, the EEG also can have significant differences. Now, there, Dr. Eberson tried to differentiate the spikes of this EEG recording from the temporal lobe epilepsy, and we broadly tell into type 1 and type 2. And type 1 has a small region of negativity in the anterior temporal. So when we see type 1, it helps us because it's one, it is very good localization, and number two, it may help us to prognosticate also that because there is a small area of negativity, the results of the surgery is going to be good. So this is an example of right temporal spikes coming from the right anterior temporal region, and this is a type 1 Ebersol type, and it's very anterior medial type, and in contralateral central region you may see this is because of the dipole effect on the, so surface negative in electrophysiology, what is up is surface negative, what is down is surface positive. Similarly, another one, this is type 2, and here the area of negativity it is little more, and the contralateral dipole is also very widespread. Now you may have situation of bitemporal independent discharges, like here Dr. Keshav showed there was a hippocampal sclerosis on both the sides. So you see more frequently it is on the right temporal region, but less frequently on the left temporal also you are seeing. So it may give an idea, possibly it is more from the right temporal than from the left temporal. So we see the EEG in entirety and then see like percentage which is 60% from the right side and 40% from the left side, or it is equal. So we make, when we see the EEG, we try to see spike load is more from which side. Now, other than spike, we may see slowing also, and this slowing may be in the form of intermittent polymorphic delta activity. From the right side temporal, here we are seeing polymorphic delta activity. We may see sometimes left temporal also. You can see here polymorphic, these are slow waves, and this is the spike. So in addition to spike, you are seeing slow waves. So this also gives an idea of the abnormality. There is another term known as temporal intermittent rhythmic. So you can see rhythmic delta activity. Now this has got almost equal weightage like spike. So it is coming from the left temporal region, and this is known as TIRDA. So this, till now we were talking about interictal EEG, that is when we see the routine EEG in between the seizures, what happens. Now then comes the video EEG. In the video EEG we try to record the habitual seizures, see what kind of seizures person is having, have a correlation with the video and the electrophysiology, and this is the mainstay along with MRI for the pre-surgical evaluation. And since video EEG is done for hours together, days together, we get both interictal recording, ictal recording, and the video part of it. So this is a patient, suppose it has got a gliosis on the right posterior head region, and from the similar region you can see that right C4 there is a rhythmic built up of theta activity, and then the spike starts coming in. So this is an ictal EEG. So this is a typical patient with medial temporal epilepsy. He has automatisms of the right side, hypomotor. You can see there is a dystonia of the left upper limb. This person has right-sided hippocampal sclerosis, and ictal EEG shows built-up of fast, and then there is a theta activity from the right temporal region. This is another patient with temporal lobe epilepsy. He starts having attack, hypomotor. The relative doesn't realize. There is a automatisms with the right upper limb. The left upper limb is kind of still not moving. He starts turning to the right side, and then you see there is a posturing slightly starting on the left side. So he also has a right-sided hippocampal sclerosis. The automatisms is ipsilateral. Dystonia is always contralateral, and you can see rhythmic built up from the right temporal region. This is ictal EEG. So again, the ictal EEG patterns in temporal lobe epilepsy can be divided into type 1, type 2, type 3, and within that ABC. So I'm not going into the detail, just show you some examples, like a 47-year-old person with seizures since 14 years of age, having febrile seizures in childhood. The person had seizures of aura of fear, loss of awareness, bimanual automatism, MRI showing bilateral MTS. So you can see that on the left temporal region, there is a built-up of fast activity. Then there is a rhythmic theta built up. So suggesting possibly the seizure onset zone or the ictal onset zone is from the left temporal region. Then it spreads to the other side. Similarly, a 40-year-old lady, seizures from 10 years of age with abdominal discomfort, déjà vu, behavioral arrest, bimanual automatisms, left-sided MTS. And you can see ictal EEG showing left temporal fast activity coming from the left temporal region. Another person, and no aura, has seizures characterized by behavioral arrest and bimanual automatisms. So here you can see that there is a short run of ictal activity from the right temporal, then there is a polymorphic slowing across the right temporal. So ictal onset zone is from the right temporal region. This is another person who has in the EEG, you can see runs of spikes coming from the right temporal region, and during seizures these spike stops, and then there is a fast activity here from the right temporal region. Person has a very severely atrophic right temporal hippocampus or vested hippocampus. In sleep, it is said that you can get increased number of spikes because of the desynchronization in the non-REM part of it. So now the EEG we record across the scalp. Scalp is a bad conductor. So you see an example of man versus crane. The crane sees the fish correctly, whereas the man like us, we will be seeing the fish. This is a true fish and this is an illusion. So quite often in our EEG, we see a wide spectra, a widespread, or not actually where the source is coming from. So there the role of MEG is there. So I will give you an example. This is a large apartment complex, and sound is coming from there. So we don't know when, where and what is there. So MRI can tell actually it because of it has got a very poor temporal resolution, but it can tell where it is coming and what it is. The EEG can tell when exactly, that is got an excellent temporal resolution, but very poor spatial. So we don't know where it is coming. So it is telling a wide area. Whereas MEG and can tell when and where very nicely, because we are going to see in coming several slides certain examples where you will be certain that yes, it can help in several situations about when and where, that is spatial and temporal resolution being better with MEG. Now you see this 19-year-old lady with typical temporal lobe epilepsy. So she's on 3 drugs. Scalp EEG shows right temporal sharp waves, and video EEG again ictal built up from the right temporal. Patient has typical hippocampal sclerosis from the right side. Now here MEG always is anatomical right, so several discharges were seen, what we call as dipoles, and we see a strong cluster of dipoles. These are co-registered in our MRI of the same patient. So from the right temporal region, you can see that. So here is a situation where there is an agreement between the other pre-surgical tools and the MEG. Now, when sometimes there may not be, EEGs are not very apparent, like here is a gliosis, the EEGs are not very apparent. So the video EEG showed artifact. Now these are the MEG recording. You saw the spikes here, and these spikes are coming from the right parietal sensors. We co-registered here, and there was a tight clusters. So here anatomical right is right on the area where the gliosis is there. So when EEG was not helping, the MEG picked up some spikes and co-registered just exactly with the gliosis. And so the patient, we know now there is a clinico-electrophysio imaging correlation. There may be a situation when there is a discordance with the video EEG, like a 25-year-old man with seizures characterized by typical temporal lobe epilepsy, 3 to 4 per month, multiple drugs. Clinically, person had left temporal, EEG was normal, ictal EEG showed actually right side. So there was a false lateralization from the right side. However, there was a arachnoid cyst. So we are not sure this arachnoid cyst is incidental or anything to do with epilepsy. Now we did MEG and picked up spikes, very nice, what we call as sink and source, and this is a dipole, how we get it, and it is from the left side, actually the posterior margin of the arachnoid cyst where the seizures onset was there. So Dr. Bhaskar operated this patient, and the patient is now possibly for last 4 or 5 years seizure free. So there was a situation in which MEG helped. Now MEG has a very important role when there is an MR negative situation. That MRI is normal, patient has semiology suggestive of MTLE, but I am not sure which side it is coming from. So here was a situation in which the MEG was from the right side, and the video EEG had shown it is from the left side, and person's MRI is normal. PET also showed left more than right temporal hypometabolism. So in this situation, we cannot sort it out. So patient underwent invasive recording, and patient had actually true bitemporal epilepsy. That is, we recorded 4 seizures from this side, 4 seizures from the other side. So we did not operate this patient. So MEG at least told, say red flag, no go, go for invasive recording, and we found 2 bitemporal epilepsy. Now it's another patient who has a normal MRI and semiology of consisting of left upper limb and lower limb clonic movement. The video EEG is suggestive of right fronto-central onset. The PET showed hypometabolism in the right frontal area. And MEG showed very tight clusters coming from the right posterior frontal region. So here is a situation in which MEG, though it was MR negative, helped. It can help sometimes in dual pathology, like you have a calcified lesion in the posterior head region plus hippocampal sclerosis. The interictal EEG and the ictal EEG suggested that the seizure is coming from the hippocampal region on the left side. So MEG also agreed with the electrophysiology, that is the video EEG and the EEG, that it is coming from the left temporal. Possibly here the calcified speck was incidental, or it is currently silent. So patient underwent temporal lobectomy and is seizure free now. One of the important use of MEG is when we plan for intracranial EEG placement, and it helps. Like here is a patient with the dysplasia just in the motor cortex. You can see the showing and here they say runs of spikes coming from the same region. So here both the EEG source imaging and the MEG source imaging, what we call is MSI, showed that yes, it is coming from the same area where the anatomic right is where the lesion is. So it is coming from the same area. So this patient underwent intracranial recording, and now situation in which MSI and ESI has a complementary role, and both showing that EEG and the MEG coming from the temporal lobe. It has got certainly some role in surgical failure. To give you an example, like one patient came with dysplasia, operated, having seizures. So the post-op MEG showed the clusters coming from the posterior margin, suggesting that there was incomplete resection. Patient underwent repeat surgery, and after that is okay. Sometimes in poorly localizing situation in which the EEG and video EEG is very widespread, it helps, and this is an example where it helped. Now, I'm not going into the detail.
Sanjeev, you need to conclude. We've run out of time.
Sure. So you can use for functional pre-surgical mapping like fMRI using either somatosensory or visual evoked, even auditory evoked field, and even motor ones can do. And so these are the various ways one can do So I will come into limitations of MEG. It's not the first order test for clinical and routine EEG diagnosis. One should remember very well. It is one of the several advanced pre-surgical investigative technologies. It cannot replace and may guide the placement of intracranial EEG, which is going to be my future next speaker. And in some patients, avoid unnecessary intracranial EEG. Need for MEG is much lower than surface EEG and anatomical MRI. Cost is an issue. It is technically demanding, and helium refilling is a big problem. This is my team at NIMANS.
Right. Thank you, Sanjeev, for a nice presentation. I think you put your points across very nicely through illustrated cases. So thank you for the presentation. We now come to the last presentation by Professor Ashok Pende. He is the professor of neurosurgery at Amrita, Kochi. He's going to be talking about the role of stereo EEG, ECOG, and CSM in management of drug-resistant epilepsy. Ashok? You could share your screen.
Thank you. Am I audible and visible right now? Yeah, I'm sorry, yes.
Then now you have to stop sharing your screen.
How's this?
Yeah, it's coming.
Yeah, it's coming now. Yeah.
You're able to see my screen now? Okay.
Yes.
And I'm audible.
Yes.
Am I audible?
Certainly.
Okay.
Go ahead.
I'll time myself to stop around 9 o'clock, I think now, 25 minutes. So at the outset, I want to thank my friends and colleagues, Dr. Bhaskar Rao and Dr. Sanke, and the society for having me to give this discussion. And I've been asked to talk about intracranial EEG and cortical stimulation mapping in epilepsy surgery. As an overview, I'll begin just by some of the historical aspects that led us to use of intracranial EEG, because it's important to understand that, so we understand the different types of intracranial EEG. Then I'll go into electrocorticogram, subdural electrode use, stereo EEG, and then a topic which is very important to me is cause control intracranial EEG, which might be the secret of the success of using it in our scenario. Sorry, these are my financial disclosures. And about regarding history, we all know about localization. If you go back to the history of cerebral localization, we initially started localizing functional areas of the brain based on lesions. For example, Broca's area based on the patient with a stroke. Or in the case of Victor Horsley, who you all know did the first epilepsy surgery, it was basically by using semiology and localizing to the motor strip and surgery. Therefore, we used surgery to localize. Ferrier in 1876 first described the idea of using electrocortical stimulation in a monkey to help us map functional areas of the brain. And this finally led to a culmination of all these attempts in 1950s by, we all know, Dr. Penfield in Montreal. And so this is a picture of Penfield doing his awake craniotomies here. And this is Jasper. So Jasper and Penfield worked very closely. And it is they who describe the concept of EEG in epilepsy. EEG, the routine EEG, which we just heard about, not just intracranial EEG. And also, then Jasper worked closely, so that the collaboration between the neurosurgeon and the neurosurgeon and the neurologist interoperatively led to intracranial EEG. That is, what would happen if we get over the insulation of the scalp, bone, and everything, and record signals, cerebral signals directly from the gray matter. And this led to electrocorticography. Very interestingly, almost simultaneously, perhaps maybe 5 to 10 years later, the group in Paris, Talleyrand and Banco, they started the technique of stereo-EEG. Now, their idea was a little bit different. Their idea was to use it, insert electrodes and do chronicle recordings, not at the time of surgery. And it is from this that the idea of chronic invasive recording has started. I like to highlight this because many times we think that stereo-EEG is a more recent technique. No, it's quite the opposite. Actually, stereo-EEG predates subdual grids in that they developed in the 1960s and 70s. And then subdual grids are basically the North American equivalent of stereo-EEG recordings. They went on to describe the classic technique of stereo-EEG, which we still use today, to intracranial EEG recordings. This is one of the most important things. And my talk is mainly meant for young neurosurgeons, and this is other neurosurgeons who are starting to get interested in epilepsy surgery. I'm not going so much into the detail of the exact technique because these are 3 or 4 different techniques that we're covering in a short amount of time. But the important thing to understand is the difference between ictal and interictal recordings. What you just heard from Dr. Sanjeev Sinha is about MEG, which is largely interictal. That means we're looking at discharges in between the seizures. Definitely that has a lot of importance in localization of an epileptogenic zone. But ictal recordings were first described here in Paris in 1960s by Talleyrand and Banco. And that continues until today to be perhaps almost the gold standard of describing the epileptogenic zone. They very importantly linked it with semiology. For all the neurosurgeons out there, semiology for me is like nobody will operate on a disc prolapse, a C6-7 disc prolapse without finding a deficit. So what are we doing? We're really correlating a neurological functional deficit with our imaging lesion. The semiology is basically your ictal neurological exam. And it still remains one of the gold standards for localization of an epileptogenic zone. And stereo-EEG is really just a confirmation of that with an electrode. But they took it level in brain mapping, and they were able to do electrocortical stimulation mapping and describe function to quite an extent that they published this atlas. And until today, much of the functional concepts of the cerebral cortex, the gray matter, is based on the Talleyrand atlas more than what we know. Because if you look at the stereo-EEG concept that Talleyrand introduced, it is basically, there's no limitation between covering the surface versus the depth of sulci, which is one of the main things that put them, I would say, one step ahead of the Montreal or the North American group who were focused mainly on recordings from the surface of the brain. Because if we look at the anatomy, the functional anatomy of the brain, only about 10 to 15% of our functions will reside on what we call the surface of the cerebral cortex, which we see just upon opening the dura. And stereo-EEG kind of allowed them to unlock the secrets which reside deeper in the sulci, deeper in the intrahemispheric surfaces, really without any limitation of. And they also developed the Eclock Frame, which is based on orthogonal entry. Until today, orthogonality is probably one of the best ways to go in placing stereo-EEG electrodes. I won't go so much into detail about that. I'll be happy to discuss it in discussion section. It's an important stereotactic concept. The Talleyrand space revolves around the frame and allowed for, prior to MRI, it allowed for defining a space and therefore assigning functions to that. Now, I want to highlight this slide. I want this to be like the take-home message of my talk, I guess, because I was asked to talk about electrocorticogram, subdural electrodes, and stereo EG. Many times you hear the discussions, which would you prefer, which would you go for? Now, I would try to answer that with this one slide, and I'll come back to it at the end so that the rest of my talk should be in reference to this. It's important for all surgeons to understand that electrocorticogram is a single-stage procedure. It's when you open up. Subdural and stereo EG is we're doing chronic recording, so we're implanting electrodes. Now, what are the benefits and what are the advantages and disadvantages? Electrocorticogram, when you're operating, gives you a real-time correlation with your resection. So you can really probe the area that you want to resect time and time again while you're doing the resection. So I've termed this real-time correlation with resection. It's very good for that. Subdural and stereo EG, that's not at the time of your resection. Though your neurology colleagues might be doing heavy mapping or heavy localization of the epileptogenic zone, you as a surgeon still have to come back and reproduce that with your hands intraoperatively. So electrocorticogram really scores high on that. And I'll come back to this to emphasize the point that this should often be combined with these. They're not separate tools. The cortical volume covered is very low in an electrocorticogram. It's only the area that you exposed from your craniotomy. Subdural is moderate. It covers a larger area depending on the size of your grid in your craniotomy. Stereo EG, I would put a little bit higher than that because we can sample more sulci and we can sample large volumes bilaterally. Surface coverage is low because of the limitation of craniotomy size in ECOG. It's pretty high in subdural and higher than what we would see in stereo EG, the surface of the brain. That may or may not translate to a benefit. Activity recorded. Again, like as I mentioned in the outset, electrocorticogram is purely intrictal. Subdural and both subdural and stereo EG allow you to record both intrictal and ictal activity. Placement accuracy. I find this a very important point. When we record a signal as a surgeon with the intent of doing a resection, we really want to be able to localize that into the area that we want to resect. Where is it? Can we resect it? Have we resected it? And where is it in relation to function areas? The placement accuracy of electrocorticogram electrodes, as you'll see or as many of you know, is not very good. Subdural grids is also pretty low because we're just placing it manually over the brain. We can then take a scan and then fuse it with brain and try to go back and record. Whereas stereo EG is exactly that. It's stereotactic accuracy. So we have planned a stereotactic trajectory and we have inserted an electrode, and therefore we know its positions in stereotactic space. Co-registry with baseline images becomes very good, very accurate, and it gives you a very accurate representation to go back and correlate that signal with that area of cortex. Stimulation mapping. It can be done in ECOG when you combine it, when you do the cortical stimulation, which I'll go into subsequently. Subdural grids is quite good. Stereo EG is actually quite good. There's a constant argument that maybe subdural grid gives more than stereo EG. In my experience, no, it's just a question of how you plan your stereo EG. And again, many times I'm going back and combining this with an awake surgery. Bilateral coverage. Impossible in electrocorticogram because it's based on a craniotomy. Very difficult in subdural implantation, probably limited to just strips. And in stereo EG, it's quite excellent. You have, both sides of the brain are open to you to explore, simply because you've just put a 2 millimeter insertion point. Morbidity. The morbidity is quite low with ECOG. It's related to craniotomy. Morbidity with subdural grids is very high, and stereo EG is very low. So I want this to be a good summary. For those for whom this is an introduction, this is basically an illustration of the concepts I just said. You just insert the electrodes, and the entire brain is your space with stereo EG. The subdural grid is you're limited to the convexity area that you've decided to expose. You can put in interhemispheric and deep areas subtemporal, subbasally, but you have a little bit more restrictions. Look at intracranial EEG use at our center. This is our use in about 720 procedures. We've used it in 31% of patients. I want to emphasize the point that this is not going to be the routine use of intracranial EEGs. Ours tends to be a referral center exactly for this, and therefore our numbers are higher. I would say in routine epilepsy surgery programs, the use of intracranial EEG is probably somewhere, not excluding electrocorticogram, I'm talking about chronic recordings, is probably somewhere between 10 to 15%. Now, how to do an ECOG? What do you need? You need a very good electroencephalographer, a good EEG person. And I even know a neurosurgeon who is, whatever it takes to do it, you have to have a very good EEG person. And it has to be just like Penfield and Jasper. You have to have a good anesthetist who can work with, number one, your neurologist, your electroencephalographer. And you have to develop and standardize your ECOG anesthesia protocol. Choose your electrodes. I'll go over some choices. And most importantly, you have to have a backup plan. Very frequently, your ECOG can be negative. It's just kind of the luck of whether you got the discharges or not when you open up into a craniotomy. Our ECOG positivity rate, when I checked here, is about 67, 70%. But you should go in with a plan like, if the ECOG is negative, what will I resect? This is very important. Anesthesia, in the interest of time, I'm not going to go too much into detail in the anesthesia protocol. ECOG at our center, we've done 128 ECOGs. I had coupled it with Stereotactically in 38 of the cases. This is the Eclock Frame which I use. This is basically a Montreal version. It's custom made. These electrode tips are silver tipped. This can be, so this is the frame which I like to use. It is reusable. We don't have an electrode cost here. You can contour to your craniotomy. I'll show you. These are the depth electrodes. I use this also. I don't really use subdural grids anymore, but these are definitely a good option as well, depending on what you have at your center. This is how the spider frame fits on. You can fit it onto a sigilla rest. There's an entry in that. This is my friend from Brazil. They fit it into the bone. So the frame you can put a hole and fit the frame into the bone, and then you can contour your electrodes and then record as you like from the surface. Now this is a surface ECOG. You can concentrate it. You can concentrate on different parts of your craniotomy. This is my endoscope holder, which I've used to hold the ECOG frame, so I can just take it on and out as I like. This is something which I developed. Now, I'd like to emphasize that I always start with this frame and do a surface ECOG. But the surface ECOG often doesn't guide my full resection, because I'm still thinking about it like Stereotactically. I want to sample further depths. And therefore, this is what I usually do. Now, this is a schematic. Supposing this is our point of focus lesion, and we record the intracranial discharges, then I keep one depth electrode in the center, which I found from my surface ECOG, and then I call that C electrode, and then I take a peripheral electrode and I rotate it around. You can see negative ECOGs here, and then finally in one point at 8 o'clock here, I get some intracranial discharges there. Now I've done a resection, and I check post ECOG. Now I still find discharges here, and then you can extend the resection and extend it more, and then you can see a clean ECOG. Now this is what I meant by being able to do real-time tracing with your resection. This is a case, a 6-year-old girl who had an MRI visible dysplasia of the occipital lobe. You see associated PET hypometabolism and ictospector showing those regions. We did electrical source imaging and it's localized there. So we have a good localization going in. My backup plan is I'm going to do an occipital lobectomy, and I combine it with an ECOG. And I see with depth electrodes, I see the spiking from the focal cortical dysplasia, and I've resected it, and now the post ECOG is showing clean. Now this is just gives you the confidence that you've resected enough. Stimulation mapping. Looks like I'm running short on time. I'm going to quickly go through my slides. You have the option of doing intraoperative or extraoperative. Intraoperative is done during a craniotomy. It can be done most commonly awake, or it can be done under anesthesia. Extraoperative is with implantation of electrodes. What to test when you do stimulation mapping. Basically, you can look for positive responses. Supposing we're stimulating the sensory cortex, the patient feels something. You stimulate the insula, the patient has a sensation. You record that at which point, and then you correlate it with your final ultimate findings. You can have negative phenomena. You have the patient speak, and the patient's naming. We use a Boston naming chart. The patient is able to name without stimulation, and when stimulation at that point, they have speech arrest. Then that is a negative phenomenon. And so that is what we use for language. In the interest of time, I'm going to go through this quickly. How much current to use? I will skip that for now. After discharge, I use electrocardiogram because seizures can be, stimulation-related seizures can be a big pitfall, and you should really use what we call the after-discharge threshold mapping to select the current to use for your stimulation mapping. I won't go into that detail now, but I will give you a reference. Language mapping. This is the object naming thing. We ask the patient to say, this is a and then in whichever language. When we do it in Hindi, we make sure that they say the last word as the name of the object. Iska naam hai cycle, like that, because that correlates with the current that we give, and we look for speech arrest. In the interest of time, I'm going to skip through this. Here's a grid can be used for that mapping also. These are the stimulator boxes. This is the box we used to use in Toronto when I was training. This is the box I used to use initially here. Different stimulator, Ojiman stimulator boxes are available. These are the mapping current details. Anyone can take. And if you like, there's a chapter which I've written, and you could take a screenshot of this, and it has the current settings. I'll show a quick case. This is a 22-year-old female who had refractory focal seizures, which began with a myoclonic jerk of the right upper limb. She had an MRI, a negative MRI, and PET was showing some hypometabolism in the left frontal lobe. And we did a grid implantation. This was done about 6-7 years ago before I started stereo EG. We mapped the functions. Again, in the interest of time, I think this video is going to take more time, but she says that something is stopping her when she gets stimulation over the Broca's area. I used to make a map literally with this so that the contact, so that I know what I'm dealing with. And then I translate that map to the surgery. And this is what I felt was Broca's. This was the face, this was the hand, this was the arm, this is the SMA, which was all mapped using the subdural grid extraoperatively. This patient had an implantation duration of 21 days. This is my longest intracranial implantation ever. And a resection was done. It turned out to be a focal cortical dysplasia type 2. She had angle 1A seizure freedom for 3 years and then had a minor relapse, and then subsequently is almost seizure free at 7 years with further drug tapering, and she's even been married and has a child now and is a dentist. So this is how intracranial EEG can be used, and that was a pathology. Now, what got me interested, this was our first stereo EEG on New Year's Day in 2014. This is when I switched to stereo EEG. Looking at intracranial EEG, I already went over this in the beginning. You can cover a large area of surface like this. You can cover a large area with a bigger craniotomy and a bigger grid and think you're covering a lot. But actually, what did they do with stereo EEG? They said, let's try to sit back and look at where it is we think it is, and then target that and put depth electrodes stereotactically and just rule in or rule out our hypotheses. That is basically the essence of stereo EEG technique. And I have subsequently adapted that. Largely because of this. The major complications in subdural grids is 6 to 25%, infection being the most common, and then there's a large amount of patient discomfort compared to stereo EEG. That was one of my main reasons for switching to stereo EEG about 7-8 years ago. It was developed in the 1960s and 70s. I like to mention this because they developed it in a time well before MRI, and therefore a lot of the technique, the inbuilt technique of stereo EEG of careful localization using semiology, using EEG. And now, of course, we have adjuncts also, like we just saw nicely from Dr. Sanjeev Sinha's talk about MEG. Use all these and try to make a hypothesis where it is. And this was all done before MRI. So a lot of the problems we have when we cannot find it in MRI, however good our MRI is, or if it's subtle in MRI, or if you have multiple lesions in MRI. A lot of things have been solved then. And this is a look at the number of publications which have come out in stereo EEG in the past 10, 15 years. It's really going up. It's being adopted more and more because we've had improved development in electrodes. We have much better software, which allows us to do what Telerak and Vancouver are doing much better, with much more finesse. And we have a better understanding of epilepsy surgery. What is the actual indication? When is it useful? What can be the outcomes? So we have more interest in that. Now, this is what I like to express, is that it is really ruling out a hypothesis. You cannot underemphasize this point. In the interest of time, I'm going to skip over some of these things. And this is basically what we've done instead of doing a large craniotomy. We've stereotactically inserted electrodes. This is a child who had an interesting semiology. Again, in the interest of time, and since it's mainly a surgical talk, I'm going to skip over the semiology. She had a normal MRI, and PET showed a very large area of hypometabolism here. This was basically we said it was hypermotor seizures with an asymmetric semiology, electrically more right-sided, and possibilities of frontal, orbitofrontal, frontopolar versus dorsal cingulate. Based on that, we formulated a hypothesis. This is what we want to cover. This is where we put the stereo EEG electrodes. And then based on what we want to rule in and rule out, this is what we found very interestingly. we saw an onset, an early onset, which is very characterized by very low voltage, fast activity from the hippocampus. Based on our seizure similarly, we wouldn't have suspected hippocampus. It is volleyed to the lateral posterior temporal neocortex. And from there, then it's volleyed to the frontopolar region. So this is mapping. And from this frontopolar region, we see a buildup of the seizure, which goes on to the actual clinical seizure. And these are things which show that it is a network. Now, we can target these with several electrodes and then now study the network disease. And then I was able to make a decision to do a wider resection here. This is all open to debate, but this patient is doing very well now, drug-free at 6 years. So this was another case of an 11-year-old right-handed male who had a very difficult MRI negative epilepsy presenting just as vomiting, stereotypic nocturnal vomiting. It was diagnosed as epilepsy, referred to us for stereo EG, and we, based on our evaluation, we were suspecting an insulo-opercular focus. This was the implantation we did. And I'm showing you just how with stereotactic accuracy now we can study the operculum, the insula, and we found the onset here in a very focal area. We could then do stimulation mapping using current settings and map adjacent functions. And this is a typical stereo EG technique. Okay, so you have some visceral functions here, distaste, you have auditory ringing, you have facial sensation, all these kind of things, tightly packed function in the insulo-opercular region. And we were able to do a very short, small resection and render the patient seizure-free for a prolonged period of time. These are over time one develops implantation schema for different types of localizations. This is a little bit beyond the scope of this talk. What are the surgical techniques? So these are the surgical techniques, obviously frame-based. I started out with frame-based. I never thought I would be able to get a robot at our center, but as our volume increased, it worked out that we did get a robot. I developed a frame device that allowed me to do very rapid orthogonal implantation. And this is what I used for the first 11 cases. Presently, I do use the ROSA robot. There are different robots out in the market, all of them which have very good availability, and you can use it to suit your purpose of doing robotic stereo EG implantation. What I would like to summarize in this regard is, out of my experience, I feel that it makes no difference. There is a slight compromise in accuracy when you switch to robotic systems compared to frame. That is my own personal experience. That is pretty much reported the world over. And obviously cost goes up significantly. Investment cost goes up on the robotic system. If you can supply it with other procedures from other things, then it helps you with that. Now, in conclusion, I would say that a low volume stereo EG center, you have a good epilepsy surgery program and you would like to do, say, on average, one stereo EG every month or every 2 months, I would stick to a frame. You have better accuracy. You don't have to take everything which can be done on the robot can be done on the frame also. It may take slightly more time. More important than a robot at that center would be a good software, stereotaxy software. The robotic system is very useful for high volume centers. Okay. And then I skip through these slides in the interest of time. Resecting. You come back to doing good microsurgical or cortical resections. Know thy brain, know the sulcal anatomy, functional anatomy, combine it with the details you got from your extraoperative, intraoperative mapping. And I very frequently use awake craniotomies after stereo EG to supplement what I've got from the stereo EG. You can use the entry holes to help navigate you in your resection, or you can combine it with image guidance. This is when I compared my initial 30 cases of stereo EG versus subdural. I found that we had shorter stays with stereo EG compared to subdural. Definitely had less complications. The most dreaded complication, of course, in stereo EG is hemorrhage. I've had, out of 192 cases, I've had 3 hemorrhages, which comes to about 1.5%, but only one was probably of long-term significance, and that was this middle one. I have had to additionally supplement electrodes, but that's only because we're taking more and more difficult cases. I don't really consider that a complication. A look at outcomes. So stereo EG, I want to reemphasize the point that stereo EG is very useful for the difficult. You start an epilepsy surgery program, this may be only 10 to 15% of your cases. As one advances over time and increases your volume, it may increase. Here, the red cases are what I have described as difficult cases, and we use that for stereo EG is used for that. If you look at outcome, so this is a study which is published in Epilepsy in Neurology India. you have different spectra of epilepsy surgery in different centers within India itself. And you have to tailor it. As you can see, we have a large area of MRI negative neocortical epilepsies at our center. And when I look at outcome, the blue here is seizure freedom. Stereo-EEG in our Stereo-EEG series, the seizure freedom was 63%. This was done 3 years ago. It's probably about the same now. This is 66% was in subdural epilepsy, subdural grids. There's not much difference between Stereo-EEG versus subdural grids in terms of seizure-free outcome. Direct FCD is when I was doing it with electrocorticogram in a single stage procedure. That was also about the same. If I look at just outcome in FCD surgeries in my series until 3 years ago, when I did a non-parametric test on that, there was no significant difference in the outcome between whether I used subdural grid, whether I used Stereo-EEG, or whether I used just a direct image guidance ECOG technique. But you have to remember, these are different cases. So obviously the ones I'm doing ECOG image guidance are image positive. So this is kind of like comparing apples and oranges. But just just keep all these tools in your armamentarium and choose them as you feel appropriate. One important thing which I'd like to show is how it helps us learn our own techniques better. When we used intracranial EEG a lot for our peri-Rolandic FCDs, we got a good handle over it. And then I started doing some when I have a very good med cluster here. This case was done without any implantation. And because we know the disease in that location better. So to summarize strengths from EEG, I think I'll skip through this, and this is my summary slide again, which I started in the beginning. I want this to be the main take-home message for most surgeons out there. I think just remember these points which I've covered in the talk. They have different uses. At present, they have different strengths and weaknesses. At present, I don't do subdural grids pretty much for any indication. I've switched completely over to Stereo-EEG. For safety, and basically that's for improved technique and the stereotactic accuracy. It's now the stereotactic accuracy of the Stereo-EEG blends into my resection procedure, or into now we're doing a lot more stereotactic cortical ablations, so it just becomes natural with Stereo-EEG. Okay. Now, I just like to briefly end up on one important topic. For the longest time, especially in our country, the main thing was the cost, and it still is. And I like to give a take-home message that, where there's a will, there's a way. At our center, we've been doing things between hospital administration and our own center, trying to reduce costs and contain it so that we can offer this more, because we have a huge number of patients who require it. To the point that about maybe 25 to 30% have undergone even Stereo-EEG and resection for less than 5 to 10% of the actual cost of the procedure. Now, what are the options to reduce costs? It's often talked about that one should reduce the electrode number. I would, in my extensive experience, I would strongly advise against this, because you risk gathering insufficient data for a difficult case that you have embarked upon. For me, it represents a wasted cost and effort. What I was taught when I learned Stereo-EEG was the ideal rule of 5 to 15. If you think you can do a Stereo-EEG with less than 5 electrodes, you're so confident of the localization, you probably don't need a Stereo-EEG. And you could do it in a single stage procedure with an ECOG and image guided procedure, and I still do that. If you think you need more than 15 electrodes, you aren't confident enough in your implantation hypothesis, localization hypothesis, and you need to rethink it, because there's a high chance your Stereo-EEG is also going to be negative. So those are my arguments on reducing the electrode number. I don't think it's a ideal or optimal way of reducing cost and making these techniques more affordable to our patients in this country. Obviously, the ideal solutions are to develop an indigenous electrode at lower cost. This is one of my long-term interests and research interests, and now in R&D interest. But I don't have much to share with you at present on that. Next is safe and effective reuse policy. What we've developed scientifically after reviewing literature, what are the risks? And I'm not going to go into that in detail right now. We hope to get a publication out for you. In about this is the technique we use, and we end up in using plasma-sterad packing sterilization, which is proven in vivo models to prevent transmission of prion disease, which is therefore superior to any other routine neurosurgical procedures that you're doing in that respect. So I'm almost done here. I can even quickly go through this. In our use of 192 patients, we have a different referral base, so we have a new electrode use in about 54% of the patients, but that's because we have a large contingent of patients who are covered by ministries of health from different countries. but we still want to be able to offer the same services to the poor and needy in our country. And therefore, we use one use or two uses. And we're studying what is the electrode fidelity after these reuses here. This is a paper which you can hope to see maybe in the next year or two, I'm hoping. I think I will summarize and end up on this slide, I think, in that if we take the reuse electrode as being cost 100%, when we did partial reuse, we were able to reduce the cost in materials, which is basically electrode, from to just 18% of that. So 82% cost reduction. When we did complete reuse, 97% cost reduction. And this is a large number of patients. And this is in procedure hospital billing, which because our decision to use or reuse is also based on the hospital characterization of that patient for other billing purposes. So I just like to show that these options are available and should not become an obstacle for developing an intracranial EEG use in your epilepsy surgery program. So finally, one has to always think about the importance of localizing and resecting, balancing that with cost and morbidity in choosing how to manage these difficult procedures in your epilepsy surgery program. Everything I've explained and presented to you is a result of a huge team of my friends and colleagues here over many years, about 10 years work. And more than the people you see on this, there are many others who remain not listed. But, so I'll be happy to end with that and take any questions during the discussion time. Thank you.
Right. Thank you, Ashok, for sharing your vast experience with stereotactic EEG. It's been a nice presentation. And I think we are open for questions now for both the speakers. Milind, do you have any questions in the chat box?
Yeah, I'm just, as of now, there are no questions which I added on. No.
So any of the sort of faculty or any person in the panel would like to ask any questions?
So I don't have a question, but I generally have, Ashok, do you want to stop sharing your screen?
I'm sorry. Yeah, I'm sorry.
Yeah.
I'm sorry.
So, yeah, hi, thanks. So I'd like to thank Sanjeev and Ashok primarily for trying to cover two topics which are probably not done at, these are facilities which are not necessarily available with significant number of centers who are interested in epilepsy. Though I just would like to make a comment on this, that it is important to know the usage of advanced investigative techniques such as MEG, and for that matter, techniques which are used in surgery such as localization using SEEG, or for that matter, any form of extraoperative stimulation. I have a slight bit of question to Ashok as such. I understand the need to overall try and get better localization, but I would like you to actually emphasize the point in terms of better understanding of stereotaxy as a necessity for someone to, take up extraoperative stimulation, particularly SEEG. So I'd like to slightly emphasize on that particular point.
Yeah, I agree 100%. Unfortunately, because of time, we couldn't go into the stereotaxy, but it's very fascinating. I think it's an entirely different stereotaxy, and that point cannot be underemphasized. I think that's one reason why I prefer stereo-EEG over subdural grids, because it's a stereotactic procedure.
Can I ask a question to Ashok?
Go ahead.
If cortical surface is flattened, I believe the surface area will be about 1.5 meters. Now we have MR paradigms where we flatten the cortex. Now after the stereo-EEG, suppose if you reconstruct the cortical surface and then show in a flat broad area, more like how you can map with a grid. Is that technique something to think about or in evolution?
Yeah, that's interesting. I think that would be interesting. I agree. I haven't done it yet. We do it. We do a lot of MR modification for the stereo-EEG planning, but post-implantation, I see what you're saying. That's more of a research. Would be interesting. Mapping. It's another cortical mapping adjunct. I think that would be interesting. Yeah. And yeah, maybe it might help you in planning resection also. It's a good idea.
Thank you.
Because
Any
we
other
use
questions or comments?
So not really from me. Just that there was a question which was asked earlier as to effectiveness of epilepsy surgery. Ashok, if you want to make a comment, or Sanjeev, maybe Sanjeev is probably a better person to answer that question. So there was a question which was asked in the previous one, Sanjeev, maybe you could take that question as to predictability of outcomes following epilepsy surgery. So that was one of the questions. That's the basically summary of the question.
No, I mean, it's now well recognized that epilepsy surgery in selected cases definitely helps. If overall, like if it is lesion positive, most of the centers which are doing surgery, more than 80%, close to 90% also, it may be in very highly selective cases, seizure free. Drug freedom may be 50% of that. In MR negative, overall, it may be about 60 to 70% for first 2 to 3 years. It drops down to 50% or even less than that in after 5 years. Now, the prediction is obviously that Sutton's law, where lesion is there if you have, and there is a electrical concordance, then that's the strongest predictor. Yes, success is very high. Moment it is MR negative, we have to do all kinds of, like the gold standard being SEEG. And there, if you are very sure, one small gyri you are able to pick up, success will be very good. If it is a wider area or there is a issue of network, then again the success may not be as good.
Can I add a point?
Sure.
Yeah.
Yes.
Laura Jahi from Cleveland Clinic published a predictive model. If you enter all the patient parameters preoperatively, the success score will come out. It's available on the net, and then those who are interested can go through that.
Yeah.
Yeah, extensive outcome study data is there. We classified as based on localization, based on imaging, based on substrate pathology, based on even factors, based on duration of epilepsy. And this algorithm which is available is there. Over time, you kind of get a sense of how to predict. And generally, so your best outcomes, of course, will be imaging positive temporal lobe epilepsy and hemispherotomies. And your worst outcomes will be MR negative frontal lobe epilepsy. And everything rests somewhere in between.
Just to get a perspective, how many MEGs are there in the country? 2 to my knowledge. Are there any more, Sanjeev?
2.
Just 2.
We have 2 MEGs, one at Nimans and one is at Delhi.
At the National Brain Research Center, James is using. And how many stereotactic EEG setups are there with the RUSA? James has one,
It's important to take ROSA out of the picture, actually, because stereo EEG can be done without ROSA.
Without the ROSA.
Yeah, so let's say, I would say stereo EEG centers, to my knowledge, doing active stereo EEG, I would say, to do active stereo EEG, I would say about 5 to 10 cases a year. So there are about close to 10 to maybe 10 to 12 now, I think. Yeah, I would say active in our country, I would classify it as about 5 to 10 per year, regularly doing it. With some training. Because training is very important on the interpretation, perhaps more important there than the insertion.
I think that cannot be more emphasized from the fact that stereotaxy is something which a lot of centers are practicing, but interpretation of a stereo EEG is probably a different ballgame altogether.
It is not at all a single person thing. It's a huge team, and more important than the insert. Well, equally, back and forth. They have to be that in sync. So it's not actually ROSA. It's more that. It's more the experience and the synergy than the ROSA.
So how how much does the ROSA add to it? It adds to the convenience. It adds to the accuracy should be fairly similar, shouldn't it?
I'm sorry, the connection got cut and I missed the question.
Right. So how much does the ROSA add to the efficacy of the stereo EEG? Or is it just sort of a convenience or?
It is, what the ROSA does is, okay, it reduces the operative time significantly. It does, depending on the type of stereotaxy that you use, it gives you more versatility in the trajectories. So you can do a lot more oblique trajectories. But going crazy with oblique trajectories really doesn't work well with stereo EEG because following an orthogonal approach from the side in just like Talerac developed still gives us a better understanding of the anatomy as we're interpreting it to do a resection because we're coming from that surface when we do a craniotomy. So that is very important. So it's mainly time reduction and a little bit more versatility in doing trajectories. Now, that's another important interest of mine in developing a frame that allows that more than this traditional Lexel and CRW frame. So frame systems are able to do that also. And it just takes more time to get the same versatility. And I would say more than whether you use a frame or a robot, it's just that you have to use a good stereotaxy software and be comfortable with that. And then have in your own sense what trajectories would be good for your particular patient. We all know as stereotactic neurosurgeon, once you decide on a trajectory, if you're careful about the entry, then you can do it. With a frame.
No, I think we covered a number of topics very elegantly. And as you mentioned, getting more knowledge about the newer techniques, the importance and where to use it, how to make optimal use of it. It's been a very useful webinar. I'm sure our members would have found it useful. So over to you, Milind.
Yeah, so I'd like to essentially highlight a couple of facts that we've had extremely good response even for this webinar. We've had more than 230 viewers to this, and a significant number of these seem to be, a combination of people not just interested, but a lot of young students and neurosurgeons, so which is quite encouraging. This, as I started off saying, that this is aimed at trying to generate more interest in functional neurosurgery, and I'm glad to see that the number of viewers is significant. And between the epilepsy surgery webinar series 1 and series 2, so far we've had, combining the two, we've had more than 537, sorry, not 537, 357 plus 230, we are talking in roughly in the terms of 587 viewers so far. And I'm sure that quite a few of them are following it up with epilepsy surgery webinar 1 and 2. And we would have webinar 3 as well, which would be covering more of the surgical aspects, which would be more aimed at resective surgery and disconnection surgery, which comes on next Thursday at the same time. And this would cover 4 important topics. One would be temporal lobe surgery. The other one would be hemispheric surgery. Third would be aimed at newer techniques in epilepsy surgery. And finally, it would be neurostimulation. So with that, we would be concluding the epilepsy surgery webinar series, and hopefully this would be equally beneficial and people would join the same. Again, it's always good to try and spread knowledge, and I'm glad that a lot of experts have joined in trying to support this cause. With that, I'd like to request Bhaskar to thank our speakers and the moderator as well.
Yeah, it's a really pleasing experience. When this webinar was planned, we thought it will give 2 sides of the coin, but it is turning out not 2 sides of the coin, but 360-degree view of the epilepsy surgery. I think possibly with the next concluding webinar, it will be comprehensive. So on behalf of the ISSFN, I thank Dr. P.P. Singh, as well as all our 4 distinguished speakers. And These webinars are being recorded. So once they're edited, in few days time, they will be on the ISS7 website. So participants will get a chance to review once again. And with that, we conclude this webinar and then thank all of you for participating actively. Thank you and good night.
Good night.
Thank you, everybody.
Good night. Good night.
Thank you. Good night.
Good night.
Bye-bye.